Hi guys, today's topic about primary ciliary dyskinesia. So this primary ciliary dyskinesia. This PCD is the congenital defects in the motile cilia. So this is congenital defects in the motile cilia. So this is the mucosa of airway and this is the cilia. So normal structure of cilia is 9 plus 2 microtubule. So any disruption of this normal microtubule structure lead to primary ciliary dyskinesia. What happens if this occurs? Clinically, if there is abnormal or defective mucociliary clearance, that may lead to recurrent lung infection, that may lead to otitis media with effusion, and that may lead to chronic rhinosinusitis. So these three are clinically present in PCD cases. They may present with azoospermia and Situs inversus. If Situs inversus associated with PCD, that is called Kartagener syndrome. Kartagener syndrome. If this Situs inversus is not there, it doesn't mean there will be no PCD. So PCD may have Situs inversus or it does not have Situs inversus. So this is the clinically patient present to us. Then what genetic mutation lead to this? This defective ciliary motion. So these are the dynein, axoneme, heavy chain 5 defect. That may be because of dynein, axoneme, heavy chain 5 defect, or it may be because of intermediate chain defect, intermediate 1 chain defect, or it may be because of dynein, axonemal, heavy chain defect 11. So these three defect may lead to this abnormality. Now this PCD, how you will diagnose? If you take biopsy from nasal cavity or nasal secretion or lung biopsy through bronchoscope. So there will be and transmission electron microscopy. If you see, there will be defect in the outer dynamo, there will be defect in the inner dynamo, there will be defect in the arrangement, there will be absence of central core, there will be absence of radial spoke. So these arrangement may be there. So at least you have to see more than 50 cilia of different cells, more than 50 cilia of different cell under transmission electron microscope. You will find there will be class 1 defect. What are the class 1 defect? If there is absence of outer dynamo more than 50% of the exonym, then it is class 1. Another class 1, if there is combined defect outer dynamo and inner dynamo more than 50%, then it is also class 1. If there is disarrangement of this peripheral core and absence of more than 25% of the dynamo, then it is also class 1 defect. So what is the class 1? Outer dynamo more than a 50% defect, inner dynamo plus outer dynamo defect more than 50%, or disarrangement of peripheral cilia microtubule plus more than 25% defect in the inner dining arm. So this is class 1 defect. What is class 2 defect? Class 2 defect, there is disarrangement in radial spoke. This radial spoke may be defective, or there is absence of this central microtubule. So these are the class 2 defects. So these class 2 defect. So how you will diagnose this? PCD can be diagnosed under electron microscope, or you can say transmission electron microscope, or high speed video microscopy, immunofluorescence staining, or you can diagnose with genetic testing, like defect of the dining axonal heavy chain defect 5, 11, intermediate chain defect 1. So why this you can diagnose with this ciliary, this primary ciliary dyskinesia. So this primary ciliary dyskinesia, if associated with the situs inversus, means there is right side lung, then you can call this syndrome as Kartagener syndrome. So this is all about this primary ciliary dyskinesia. Thank you so much.